Welcome back to Pharmacology. We're going to go through the coagulants and anticoagulants today. So the coagulants are going to thicken the blood to help stop bleeding. Anticoagulants are going to prevent your blood clots. Fibrinolytic are basically anticoagulants, but more active. They're going to actively break down the fibrin. Antifibrinolytic are going to prevent that breakdown. Antiplatelets are going to prevent the platelet plug formation. All of these are kind of semantics, but they kind of fall into two categories. The first category, to thicken the blood and stop bleeding. The second is to thin the blood and to prevent the clots. Phytonadione is going to be the vitamin K made by plants. Menaquinone is going to be vitamin K made by the bacteria, in particular our gut bacteria. And vitamin K3 is synthetic. And the fat-soluble vitamin K is menadione, and the water-soluble is going to be menadione sodium sulfate, along with menadione sodium phosphate. So we give the phytonadione to the newborns because their livers have not properly formed yet and they have low levels of clotting factors and vitamin K. The water-soluble form is contraindicated in the newborns because it can cause the accumulation of unconjugated bilirubin, and that can cause kernicterus. Okay, so vitamin K is the cofactor for the clotting factors 2, 7, 9, and 10, along with protein C and S. So it's going to affect the extrinsic pathway of the clotting cascade. It helps the gamma-glutamyl carboxylase to carboxylate the glutamate residues of the clotting factors in order to activate them, and that allows the clotting factors to bind the calcium and the phospholipid surface. And the warfarin is going to inhibit the gamma-glutamyl carboxylase, so it's going to prevent the vitamin hydroquinone to be carboxylated into vitamin K epoxide. And then without this, it's not going to be able to form like vitamin K quinone. So in this deficiency, there's going to be caused by liver disease, malabsorption, malnutrition, along with the long-term broad-spectrum antibiotics, because that will kill your intrinsic gut flora. You use it as a prophylaxis and treatment of a clotting factor deficiency, and importantly, it's used to reverse a warfarin overdose. You give it either IV or subcutaneous, and the adverse drug reactions are going to be flushing, breathlessness, and a fall in blood pressure. Anticoagulants, the first one to cover is heparin. And there are two types, high molecular weight, which is unfractionated, and the low molecular weight, which is fractionated. The other anticoagulants are going to be direct thrombin 2A inhibitor, a factor 10 inhibitors, and the oral anticoagulant is going to be warfarin sodium. And this needs to be monitored by the lab, so we monitor sodium citrate, sodium oxalate, and sodium edetate. Okay, so heparin is sulfated polysaccharides, and since they are large and charged, they don't cross the blood-brain barrier and the placenta. So this is okay to use in pregnant women. It's metabolized in the liver by heparinase, and you give it IV or subQ. Like I said, heparin is an antithrombolytic drug, so it's going to inhibit the thrombin formation. The high molecular weight heparin is going to inactivate factors 10 and 2 and activates antithrombin 3. So this is going to work on the common pathway of the coagulation cascade, and it increases the prothrombin time and the clotting time. Low molecular weight heparin will cause a conformational change in antithrombin 3, and in doing so, it inactivates factor 10. Since factor 2 isn't involved, the APT and CT are not prolonged. So here we go. Heparin activates antithrombin 3. Antithrombin 3 is going to inhibit the prothrombin into thrombin, and in doing so, it's not going to allow fibrinogen to be converted into fibrin, so there's no clot formation. So besides like preventing the clot, this will also activate clot dissolution. There we go. Okay, so high molecular weight heparin will decrease the platelet aggregation, and since we have to monitor it, APTT has to be kept within 1.5 or 2.5 times the normal value. Clotting time should be kept within 2 times of the normal value, and you monitor it by watching the protanamine titration in an anti-clotting factor 10A assay. So the type A side effects, the most important side effect is going to be bleeding. The heparin-induced thrombocytopenia is a life-threatening state and of the hypercoagulability, and it can occur almost like a week after heparin usage. So IgG is going to be made against heparin and factor 10. So the IgG is going to attack factor 10, which is on the platelets, and that's going to rupture a bunch of them and cause a clot, right? So if this happens, you want to give them a direct thrombin inhibitor because thrombosis is being formed, right? The problem with heparin is that osteoporosis and mineralocorticoid deficiency can occur. Another sign is the transient and reversible alopecia. So as you can see here, heparin will bind to the factor 4, so PF4, and the antibodies are going to make the immune complexes. Immune complex is going to cause like the platelet FC receptors, and then they aggregate and then cause the thrombosis. So we don't use heparin in bleeding disorder. Of course not, because they already have a problem with coagulation. We're not going to make it worse. You also don't want to give that to somebody with thrombocytopenia, because this will worsen it, of course. This is not good in severe hypertension because this can cause a hemorrhagic stroke. Piles, which are varicosities formed by hypertension, this will also increase the chances of it rupturing, and if it does rupture, it's going to be very, very hard to stop the bleeding. Same deal with the peptic ulcer. You also don't give it to somebody with subacute bacterial endocarditis because it interacts with a bunch of other medications. The one you need to be worried about is like the clots from the endocarditis. They form vegetations, and this can actually not dissolve the clot, but it can kind of pry the clot off the wall of the heart, and then the heart can pump it into the brain, causing a bunch of strokes. Definitely don't use it before surgery, and you don't want to use it in people who have liver disease or kidney diseases because of the same piles, rupturing, and hypertension. Okay, so the low molecular weight heparin has a better bioavailability. It has a longer and more consistent half-life, and it is useful because you don't want to always give these people injections. You're going to ruin their veins, right? And the examples are going to be enoxaparin, dajoparin, and dalteparin. The lab monitoring of APTT and CT is not needed, so this is pretty good. But these are incredibly expensive, so not as well used. But if we do use it, and heparin in general, we use it to prevent and treat DVT and PE, of course, and you have to combine it with warfarin. We also use it to treat unstable angina, and we use it to maintain the patency of the cannula and the shunts. So we don't want these to be we want to keep it open, because if left alone, the body can fibrose over the cannula and the shunts. Okay, so protamine sulfate is going to be our heparin antagonist. It's going to be used to treat a heparin overdose. Interestingly enough, it is obtained from fish sperm, so that's cool. It inactivates heparin by electrostatic interactions, and it antagonizes the effects of both high and low molecular weight heparin, which is pretty good. The adverse reactions could be flushing and bronchospasm. Okay, so anticoagulants. The direct thrombin 2A inhibitor is going to be lepirudin, bivalirudin, and desirudin. And lepirudin is a recombinant preparation of heparin, which is made by leeches, which is super gross. Bivalirudin and desirudin are heparin analogs, and bivalirudin is the alternative to heparin if there is hepatic disease. The side effect, of course, is bleeding. Argatroban is a thrombin inhibitor. It's a synthetic parenteral anticoagulant that's made from L-arginine, and it can be used in renal dysfunction. So you use it in the prophylaxis and treatment of DVT with HIT. You can also use it as a percutaneous coronary intervention to keep the coronary vessels patent or to help distribute, and you give it as a continuous IV. Okay, so the oral medication, dabigatran etacillate, is going to be your thrombin inhibitor. And it's a prodrug, and it prevents strokes and systemic embolism, especially in patients with atrial fibrillation. So a pretty good drug. Factor 10 inhibitors, fondaparinux, will selectively inhibit factor 10A. So this will inhibit the common pathway of the coagulation cascade. It activates antithrombin 3 and is a prophylaxis to treat DVT and PE, and it is injected subcutaneously. So it works basically the same as heparin, but the problem is it's not reversed by protamine sulfate, so use with caution. It is pretty useful because it can be in an oral form. So rivaroxaban will prevent and treat DVT and PE for prevention of stroke and atrial fibrillation, and apixaban is going to be your stroke prevention and atrial fibrillation. So AFib, with the problems with regular contraction, there is a much higher risk of forming thrombosis. Apixaban we use a lot in the hospital. Okay, so warfarin is going to be the same thing as Coumadin. You probably heard of Coumadin. And it inhibits the vitamin K epoxide reductase. So remember we went through the biochem briefly about that. Vitamin K is used for all of the, well, not all of them, but a good majority of the clotting factors, like 2, 7, 9, 10. And they will be needed in order to clot, and warfarin is going to inhibit all of this by just like inhibiting the bioavailability of vitamin K in general. So the problem is you can't start it alone because there's going to be an early depletion of protein C. So the early depletion of protein C is going to lead to increased thrombolytic incidences. And skin necrosis occurs about 3 to 4 days after warfarin therapy. So we have to give it with heparin. It can't be started alone. There is a very fast and complete absorption from the intestines, and it's metabolized by CYP2C9, and since it's complete absorption, it's 99% bound, so it can interact with a lot of different drugs, and it can be very, very dangerous. So which drugs do you have to be worried about? Aspirin, indomethacin, phenytoin, and probenecid will displace warfarin. Warfarin is also not great because it can cross the placenta and cause genetic polymorphisms and increase toxicity because of the defect of vitamin K epoxidase reductase gene. It's still kind of useful though. You give it to prevent DVT and PE. It can be used to treat rheumatic heart disease along with atrial fibrillation. It's very good in patients with prosthetic heart valves, those after vascular surgery, hemodialysis. It can treat unstable angina and prevent strokes. So we use warfarin, dabigatran, and rivaroxaban, to prevent the strokes. The most important side effects to keep in mind is the internal hemorrhage. One of the big signs are going to be the skin necrosis, and another sign is going to be alopecia, dermatitis, and diarrhea. Okay, so we cannot be giving this to pregnant females because it leads to something called Warfarin syndrome. And there's going to be a hypoplasia of the nose bridge. There's going to be problems with eye socket development, abnormalities in hands, and there's growth retardation. And there are a lot of interactions with warfarin, or like with other drugs. Like it increases the toxicity. So what will interact with it? The broad spectrum antibiotics, cephalosporins, those that decrease vitamin K synthesis, and hypoprothrombinemia. Chronic alcohol abuse will decrease the clotting factors, increasing the toxicity of warfarin. Enzyme CYP450 inhibitors we have to be worried about are grapefruit juice. The inducers are going to be St. John's wort, and our contraceptive pills we have to pay attention to because these will form blood clots. This is an anticoagulant, so it might allow the blood clots to break off from the wall of the endothelial or the endothelial walls of the vessels and get transported. Okay, so there's a certain dosage that we follow, but if there is any toxicity, you would give the vitamin K, and that takes about 24 hours to take effect though. So if there is continuous and severe bleeding and you already gave the vitamin K, you want to give the patient fresh frozen plasma. Why? Because we don't need the blood, we need the clotting factors, and that's going to be in the plasma. Fibrinolytics and thrombolytics are going to be curative. They help in the actual recanalization of the occluded blood vessels. So it's not going to thin the blood, it's actually going to break up these clots. These are clot-busting drugs. The plasminogen activators are streptokinase and urokinase. Remember, activators are generally enzymes, so ASE is a suffix for enzyme. The recombinant tissue plasminogen activators are going to be alteplase, reteplase, and tenecteplase, and those are going to be clot-selective fibrinolysis. So that's pretty good because there can be fibrous tissue kind of found wherever in the body. So for this to target just the clots is good. You don't want it to be too general. The other plasminogen activator, streptokinase, is going to make a complex with the endogenous plasminogen that undergoes a conformational change, and then it's going to be non-viable, so fibrin is going to be degraded. There is no selectivity for the fibrin-bound plasminogen, so there is higher risk of bleeding because it can kind of bind to whatever fibrin. It's antigenic, so there can be a lot of adverse drug reactions, such as anaphylaxis and hypersensitivity, but we use it because it's cheap. Urokinase is going to be non-antigenic since it's made from cultured human cells, and it directly activates the plasminogen. Problem is expensive. So redoplase, alteplase, and tenecteplase are going to activate the fibrin-bound plasminogen, which is good because it's going to be more, not direct, specific. There we go. So you use that to treat the acute myocardial infarction to recanalize, and you also use it to treat the non-hemorrhagic stroke. This is good because these are usually made out of a fatty thrombus, right? So in other diseases that need recanalization, we use it, and it's absolutely contraindicated in patients with hemorrhagic strokes, active bleeding, surgeries, like either planning to have a surgery or already have a surgery. Any kind of bleeding disorder is non-antigenic, so it doesn't cause the hypersensitivity reaction, and because of that, it is expensive. Epsilon amino acid or caproic acid or tranexamic acids are going to combine with the lysine of the plasminogen and plasmin, prevent the attachment of the plasmin to form the plug, and it is going to use to stop bleeding during surgery, trauma, postpartum hemorrhage, the abruption of the placenta, menorrhagia. So this will prevent the fibrin from being breaking up. So this isn't going to increase the clot formed. It's just going to prevent the clot that's already there from being broken up. So this is a pretty good drug, right? So it's not going to add to more clot formation. There's a less risk of having a stroke. The antiplatelet drugs, thromboxane synthesis inhibitor is going to be your aspirin. PDE3 inhibitors are going to be dipyridamole and cilostazole. And the ADP receptor or the P2Y12 blockers are going to be ticlopidine, clopidogrel, prasugrel, and ticagrelor. The reversible GP2B3A antagonists are going to be abscimab, eptifibatide, and tirofiban. I don't know why they make these drug names impossible to pronounce, but this is going to be your monoclonal antibody, and this is going to be some kind of growth factor, and these are incredibly expensive. Aspirin is going to inhibit COX-1 and thromboxane synthase in the platelets. In high doses, it will inhibit thromboxane A2 and the prostacyclin 2. So this will increase the bleeding time for about like 5 to 7 days. Pretty good because you block this at this point. So arachidonic acid to prostaglandin G2 blocked here. There's not going to be any inflammation, tumor growth, invasion, or metastasis. So a good drug. Dipyridamole and cilostazole will inhibit PDE3 and the platelet aggregation. Ticlopidine and clopidogrel will inhibit ADP induced platelet aggregation, and that blocks the platelet ADP receptor P2Y12. Clopidogrel is a gain of function prodrug, and it's affected by polymorphism. Abscimab, eptifibatide, and tirofibin are going to inhibit the platelet aggregation by reversibly blocking the GP2B3A receptor. So we give these as a prophylaxis in myocardial infarction and unstable angina, along with the coronary bypass implants, once again to maintain patency. We want to give it to prosthetic heart valves and hemodialysis, and all in all, to prevent strokes. That's it for now. Thank you for your attention, and good luck studying.